Goodbye. Goodbye.
Hello, Michael. How are you?
I'm very well, Boyan. Thank you. Can you hear me okay?
Yes, everything is okay. Thank you very much for joining us. It's a great honor for us to have you. I know that it is early in the morning in US, and I'm very grateful that you accept my invitation to join us in this panel. First of all, let me introduce you to the audience, and I would like to thank the audience that they have been with us from about 8 hours ago, and I'm sure they will enjoy your great presentation. Professor Dr. Michael Kowolik is Executive Associate Dean and Associate Dean for Faculty Affairs and Professor of Periodontics, School of Dentistry, Indiana University, US. And he kindly accepted my invitation for a lecture on global antibiotic resistance, a growing concerns and our responsibilities in this panel. Thank you very much, Professor Kowolik, and the platform is yours.
Well, Professor Boyan, thank you, and good morning, good afternoon, evening to everyone. It's not just so much the time of day here. We had a big snowstorm during the night, and there is another one coming, so it's causing some issues for the school. In fact, I think our clinics are going to close today because of the snow. It's a great pleasure to join you, and thank you all for this, and realizing that you're coming to the end of your day. I think it's my job to try and keep you awake and engaged in this, and I hope to do that. Also, seeing the video just before this started really made me very nostalgic for being in Iran again. It's 2 or 3 years since I was able to be there, and I'm hoping very much, for all the obvious reasons, to get back there sometime soon and to see my great friends, Professor Boyan and many others that I've come to know there, and of course the beautiful country and the culture. So that having been said, I should just make one part of explanation. My career has mostly been built on research, clinical research and laboratory research, and The reason I'm talking about this topic today is because after many years of the privilege of being around the world in many different places, I started to see the issues of antibiotic resistance. So this is me talking. I'm not speaking on behalf of any university or institution. This is the Kowolik version of how I see antibiotics in the world at the moment. And I'm going to hopefully share my screen with you and get this in where it should be, I hope. This is, technology is not my strong point. Can you see my screen?
Yes, it's great.
Great, thank you. Okay, so the responsibility is for all of us, and as not just as clinicians, not just as dentists or doctors, physicians, but as human beings, as family, if you like. And I want to sort of elaborate on this. And I'm going to make a very straightforward statement and unambiguous to begin with. And by the way, if anybody wants to interrupt me, I don't know how you're running this conference. I'm happy to be interrupted, or you can ask me anything at the end, or send me a message. My email address is there. But I want to start with the view I take, which is that antibiotics are dangerous drugs. And they have a tremendous value in society, but they have been horrendously misused, abused, overused, and in all the world. In the US, especially in China, the UK, Iran, anywhere you can imagine. And I'm not going to take the time to do it today, but there are publications on this from every part of the world, and Iran too. There are up-to-date publications from Iran, particularly with regard to E. coli resistance in Iran. It's a big problem at the moment, and all over. So, you can look at this yourself. Certainly, they have a place. They have a place to treat infection. For example, sometimes with an abscess, acute necrotizing ulcerative gingivitis. I'm a periodontist by training. Maybe preventing wound infection, third molar extraction surgeries, although there's very little evidence for that. Evidence is not good in antibiotics. And of course, you may want to prevent infection in compromised patients who have immune issues. And I'm going to talk about endocarditis a little bit later, because that's been a major issue in dentistry for decades overall. Many of you will never see acute ulcerative necrotizing gingivitis. This whole area here is an ulcer, very painful. It's one of the rare periodontal or gingival conditions that actually are painful. And this is just one great long ulcer in a neglected dentition, a lot of debris, calculus, plaque here, and neglected tooth here. And this is a condition that typically in well-nourished societies affects young adults, always tobacco users, always cigarette smokers, stress, poor oral hygiene, a combination of factors. And because it's so destructive, because the ulceration is so destructive, generally dentists, periodontists, and so on will use some antibiotic in conjunction with the cleaning, with the debridement and the cleaning. By the way, I'm not going to talk about antibiotic doses and so on. That's something that will definitely put you to sleep. And I'm sure for the students there that you get all this in your therapeutics classes. That's not what I want to focus on today. Implant placement, of course, has become a global multi-billion-dollar business. And of course, it's expensive as well as intensive with regard to therapy. So, if you get a peri-implantitis like this, you might, under some circumstances, want to supplement any treatment with an antibiotic. The point is that in dentistry, in general dentistry, and I can speak from the point of view of periodontics, because after general dentists and oral surgeons, mostly antibiotics are prescribed by periodontists. And there have been many, many studies since the 1970s and 80s looking at adjunctive use of antibiotics, first of all, mostly systemic and then topical, in conjunction with non-surgical and surgical periodontitis. And you'll see this meta-analysis is from a few years ago. But the point I'd like to make here is this was based on a lot of studies. And whenever Cochrane-type analysis is done, meta-analysis is done, people will go to the literature, find all the studies that they can possibly find. And inevitably, you find that the number of studies that qualify under the terms of a real systematic review are very few. And this is even worse in medicine, let me tell you. But in dentistry, it's pretty bad. And in this sort of case, they find that for moderate disease, the benefit of using adjunctive systemic antibiotic was a 0.18 millimeter gain, right, in attachment levels. And in the deeper sites initially, which were 4 to 7 millimeters, the gain was about twice as much, nearly 0.4 millimeters. So statistically, it looks nice. You know, there's a gain, and there's a gain here. Clinically, I simply ask you to ask yourselves, and the periodontist and anybody who does periodontal probing, how do you measure 0.4 of a millimeter or 0.2 of a millimeter? And as a periodontist, maybe some of you think this is heresy, but I would really argue that this is a minimal gain. Of course, these are mean values. So what it means is, for sure, in some cases, the gain was more. In some, it was less. But it's concerning to me when you consider that there are other aspects to antibiotic therapy that these values are not so much better. And the very few studies, by the way, that have been conducted for a long period of time, most periodontal studies are conducted between 6 months and 2 years. The disease is chronic, and the few studies that have followed up on those studies after 5 years or so, actually, usually the effect, the benefit is lost. There are, of course, I want to try to be fair here. There are many papers suggesting that there is an advantage here. We were looking at implants and fewer implant failures where antibiotics were used in the Journal of the American Dental Association here. Sometimes this combination therapy, which in Europe and many parts of the world is allowed, metronidazole with amoxicillin, metronidazole is not permitted for use generally in the US. I don't know why, it's a pretty useful drug. However, this was in a diabetic population and found that there was actually a benefit. So, you know, that this can be shown, and I don't want to be biased in this, but the problem, of course, is the biofilm. Here is plaque on the teeth, an exaggerated version. I've spent a lot of my life doing experimental gingivitis studies where you deliberately allow the plaque to accumulate. That's another whole story. And here you can see, even without any sort of disclosing, you can see the plaque on the teeth pretty clearly. And of course, this is the biofilm. For a long time, just thought to be a great big mess of bacteria. And now, of course, we know the biofilm is incredibly well organized. Populations of bacteria that evolve over time and are really tough to get rid of with just drugs. Of course, scaling mechanical therapy is the norm. These are not unusual. We should not be surprised at the way the bacteria developed. Theodore Rosebery, way back in 1928, which is getting on to 100 years ago, he looked at bacterial sites in the body and sort of put them together and started seeing patterns, which of course, more recently with the technology we have are very clear. Lederberg, of course, was the first to use the term the microbiome. This is not something brand new in the 21st century. 1947, he termed the phrase microbiome. And then when we thought that bacterial resistance genes could only occur between the same species, guess what? You have horizontal gene transfer. And to be very blunt about it, this is like an E. coli transferring resistance plasmids to a strep mutant if they ever show up in the same place. And to be, if you'll forgive my rather crude analogy, it's a little bit like a giraffe having sex with a rabbit. Completely different species. So this is very concerning with regard to gene transfer for resistance in antibiotic use. And the other part that I sort of did this rough calculation some time ago is when you think about how quickly bacterial populations regenerate and how quickly or slowly human populations regenerate. As a rough calculation, bacteria can go through about 250,000 mutations in one human generation, which means we take 5 million years to catch up, which means we won't catch up with the bacterial mutations. And as you know, and if you can see this slide, it means that the human karyotic population of cells, and of those our own innate cells, are around 10 to the power of 13, however many trillions that is. And the other cells are about 10 to the power 14, 10 times many. In other words, we are outnumbered about 10 to 1 by our bacteria, which are by and large really essential, so-called commensal, really essential bacteria that we don't want to spoil and disrupt, but we do it. And back to what the early scientists were looking at, Theodore Rosebery and others, when we look nowadays with the sophisticated technology we have at different sites, for example, the reproductive tract, intestines, the mouth, the airways, the skin. There is a huge amount of commonality when you look at the dendrograms of these bacterial populations. Shouldn't be surprising. You know, we are one organism, one large organism. The bacteria are well conserved by and large, with some, of course, exceptions in the different sites. So the bacteria there. This is a slide showing, this is just a few years ago, showing the prescriptions. I touched on this before, by dentists in the US. This is, of course, data. It always takes time to catch up. Most, of course, are using amoxicillin, clindamycin, some penicillins, and then others here. But as I said before, general dentistry accounts for most, obviously, numerically, then oral surgery, and then periodontics and endodontics and others come after that. But a lot of prescriptions are written. And of course, again, I just want to emphasize, if we look at our patient pool, the patients coming into your dental office who may receive antibiotics from you, from the dentist, from a specialist, and so on, but they're for sure going to be having more antibiotics from their physician, from your physician counterparts outside. That's where the biggest bulk of this goes on. And then with the attempt to try and get people to think about prescribing antibiotics. This is a paper from JADA from 2016, and the title speaks for itself. Antibiotic prescribing by dentists has increased. Why? And the article goes on to this to discuss. And one of the biggest reasons, of course, and certainly in this country, is that, of course, the population is aging, and older people have more diseases, and older people have more infections. They're more prone to infection, and of course, thereby may require to have more antibiotics prescribed for them, for their conditions. This is a paper from the Journal of Periodontology from just a little while back. And as you see from the title, comparison of azithromycin and amoxicillin before dental implant placement. And the punchline from this paper was to say that by and large, azithromycin and amoxicillin actually were pretty good in combination in this treatment. What concerned me about this, I read the paper twice in great detail, because what concerned me about this, nowhere, and this is a reputable group of researchers from the US, what really concerned me was that nowhere in the article at all did they say, by the way, when you're prescribing antibiotics, look out for resistance. Azithromycin, and you can look it up, you can Google azithromycin, it has a lot of potential side effects, including cardiotoxic effects. It's not a drug that should be given lightly. And my comment here, aren't we treating the whole patient, including their flora? And if my dentist wanted to give me azithromycin, I would want to have a really good reason, justification for me as why I should be taking azithromycin. It's not a common drug, and it should, or rather, it is more commonly used, it should be, but it is not a first-line treatment. So it's not just Kowolik getting worked up about antibiotic resistance. It's been discussed for a very long time. This was from year 2000, over 20 years ago, right? And this was in CNN, right? Not a medical journal. It was reporting on a World Health Organization study looking at antibiotic resistance and, you know, really sounding the alarm about what was going on. This is a review from the CDC, the Center for Disease Control, that puts out a bulletin every now and again from a couple of authors who did a review of antimicrobial resistance. But the quote that they made in the start of their paper, and I'll read it to you, I'm not sure how clearly you can see it. It says, antibiotic therapy, if indiscriminately used, may turn out to be a medicinal flood that temporarily cleans and heals, but ultimately destroys life itself. That's a pretty heavy statement. And the person who made that statement was a Dr. Felix Martí Ibáñez in 1955, not long after antibiotics came on the scene. A rather far sort of visionary view, and really quite stunning when he says, but ultimately destroys life itself. That is really quite concerning, but actually has turned out to be true. And we'll finish up at that point later on. Antibiotic resistance has consequences. Mortality, people die, right? If you have, and we'll come back to that in a moment. Prolonged illness costs more money to treat, looking for more drugs, and of course, limited solutions. Why? Because, to be very blunt, antibiotic research and production does not make money for pharmaceutical companies. You need, pharmaceutical companies thrive on drugs that people have to be taking for a protracted period of time, chronic rheumatoid arthritis, chronic inflammatory diseases, depression, all sorts of other things. I'm sorry if I sound terribly cynical about this, but there have to be investments made in antibiotics if it's going to make a difference. And unfortunately, that is not an area. I'm living and working in the city of Indianapolis, Indiana University here. It's the world headquarters of Eli Lilly that make a lot of drugs, Prozac, all sorts of other drugs, Cialis, a lot of things that make them billions and billions of dollars. When I first moved here, they had a huge infectious diseases division that was really looking at some of the big problems in infectious disease. There isn't an infectious disease division anymore in that company. Doesn't make them money. Sorry, you can throw stones at me if you like, if you think that I'm being too cynical, but those are the facts that's there. So in the US, about 100,000 people die each year from hospital-acquired infection. It used to be a kind of a joke, but it's not really funny, that the best place to go and get a antibiotic-resistant organism is go and visit somebody in a hospital. 140,000 visits to the emergency room every year related to antibiotic side effects. Some are allergic reactions, of course. Not all are to do with resistance. Currently, around 5 to 7% of the US population is allergic to penicillin, according to the National Institutes of Allergy and Infectious Disease, Dr. Fauci's stomping ground, right? And of course, allergy to penicillin doesn't go away, so it becomes cumulative over time. Pretty well, any patient that is young and has an allergy to penicillin is going to be allergic for the rest of his or her life. That's the way it is. You probably know some of these people. So here's a Wall Street Journal from a few years ago. What on earth is anything to do with a business journal like this? Got to do with antibiotics? Well, really, the front page story here was about hospitals and infection rates. Why? Because Raymond, who was 10 years old, was the son of a very prominent businessman in New York City. And Raymond fell off the wall in his garden while he was playing. Little boys and little girls do that when they play in the garden. He broke his leg, went into hospital, and he got osteomyelitis with a antibiotic-resistant staphylococcus, right? Raymond could have died, but fortunately he didn't. But his father was incensed as why his little Raymond was so seriously ill. He had tons and tons of money, but the tons and tons of money weren't going to stop Raymond getting a drug-resistant bacterial infection. And that's why it got into the Wall Street Journal. For every Raymond, there are many of us who will never be famous enough to be in the Wall Street Journal, but Raymond was. Methicillin-resistant Staph aureus has become a big, big problem in many parts of the world, and it often starts as a pretty innocuous skin infection. So we looked, and this was with a student here, Rachel Dunlop, who worked with me a few years ago, and my colleagues, and we looked at MRSA, methicillin-resistant Staph aureus, on dental student computers, and we found quite a bit of it here on the computer. What we were looking for was disinfection protocols, and there were the number of isolates before and after disinfection. Our protocols apparently weren't very good. MRSA, fortunately, there weren't too many, but you'll notice before there were 11, 8 after. We were a bit concerned, and the study was small, so we did another study looking with a different student, Eric Westergaard here, published it in the Journal of the American Dental Association, looking at impression guns and how they were cleaned. And this time we did a rather more sophisticated experiment. We looked at 5 disinfection protocols, and in the process, we found one that actually really worked. Now, how much is MRSA a problem in dental clinics? We don't really know. It's not well documented, and if anybody needs to sleep well at night, there's no real evidence that patients are at risk, or operators are at risk, or dental students are at risk if all the correct usual clinical protocols are engaged. So I don't want to frighten anybody with that, but it doesn't mean to say the bacteria can't be passed on. The big thing about the mouth, of course, is we're in contact. The mouth is in contact with the outside world and the inside world. This is one of the great the great strengths or great weaknesses of the oral cavity. So it's at crossroads of where antibiotics go into the body, out of the body, can be passed on. Resistance genes can be passed on to other people, to other sites. And that is one of the issues that we have in dentistry. Here's a cartoon, and I leave you just to look at this cartoon because it's really saying is that, although it's humorous, of course, it really is that the resistance genes, the plasmids and so on, can be passed on, as he's sort of suggesting here, in the hotel kitchen, in the restaurant kitchen, in any site you can imagine where bacteria interact. And it's kind of a, it's a humorous thing, but it's there. Not just Raymond. This is, some of you, I'm sure most of you are far too young to have been much involved with James Bond movies, but some of you may have seen them. But this goes back, this young lady was one of the James Bond heroines way back early in the movies, and she died last month from a urinary tract infection that was untreatable, right? Now, here she is, a film star, and you can read this here. Leading up 31% of sepsis cases start as a urinary tract infection, particularly in women. It's very common. Most women will go through their adult lives and have at least 1 or 2 episodes, some many more, unfortunately, of urinary tract infections. And of course, they're treatable, but they're not always treatable if not treated the right way and if the drug is not effective against infection. So again, somebody famous here, and for everybody famous, there are those who are not so famous, who are succumbing. Another area of great concern in the world is tuberculosis. When I was a young man in my career, the TB, like other diseases, like smallpox, which of course is a viral disease, TB was on the way down. And then, of course, the HIV/AIDS pandemic or epidemics hit, particularly in sub-Saharan Africa. And most people who die at the moment of TB in the world are, it's an AIDS-related issue, not all, but AIDS-related. Now we have XDR TB, sounds like a game show, but it's actually extreme drug-resistant tuberculosis. Again, when I was a dental student, there was a simple cocktail of 3 drugs that would treat tuberculosis pretty effectively. We're now on several generations up of antibiotic combinations to try and control it. And in some cases, TB is now untreatable in some parts of the world. A lot of people die from it. And a few years ago, the Journal of the American Dental Association saw fit to publish an article about tuberculosis and where dental settings come in. Remember, a lot of patients with tuberculosis will be silent. You won't even know they have it. They won't know they have it. They may be carrying it. They may be coughing it out. It may be a long time before they become symptomatic. They may never become symptomatic. But it is a big, big problem globally. So last year, the World Health Organization produced their data last year for 2018. Again, it takes time to catch up. 1.5 million people died from TB in 2018, and including 251,000 with HIV, as I was saying. This is a big concern. And then 500,000 fell ill with the drug-resistant tuberculosis. Really, really concerning. And only 1 in 3 had access to treatment. Of course, again, a lot of this is in populations that are less well off in sub-Saharan Africa and so on. And I put a comment in a while back that possibly in 2021, because TB is #1 infectious disease killer in the world, and I put a comment in here towards the end of last year, perhaps that COVID-19 might take over. Well, it certainly has, because the last time I looked the other day, the death toll for COVID-19 in the world is now more than 2.3 million people. So although, of course, it's a virus again, and TB is a bacterium, it's still an infectious disease, as we all know. I don't need to tell you about COVID, where we are. So multi-drug resistant TB is a big problem. There are a lot of children in the world with multi-drug resistant TB, again, mostly, but not all, in Africa. We're looking at the evolution. It's an extraordinary organism, and I don't have time to discuss that now. And you have pathologists and microbiologists there who can go into this in great detail. But this lineage 8 is a particular organism they found in a man in Africa, looking at the evolution of this extraordinary bacterium and the resistance that it can manage to mount against drugs. So this is a conference from October, this last October, a meeting of an expert committee in the World Health Organization looking at drug-resistant tuberculosis, a big problem overall. And then with the evolution of bacterial populations, other things come along. In my lifetime, the Legionella infection became known. It hadn't appeared before. It moves from soil through animals. It got into the air conditioning system in an American hotel, and the rest, as they say, is history. And now we have more and more organisms, bacteria and viruses, moving through the food chains, if you like. And now we have Candida auris. In dentistry, we know a great deal about Candida albicans. You know, it's a classic in dental education. But Candida auris is a pretty nasty form of Candida that can really affect and kill people. And it's been emerging increasingly because it finds a niche that is created by the absence, the removal of other bacteria. So of other organisms. Obviously, this is not a bacterium. Candida is obviously a fungus, but it's an illustration of this. To make it worse, we have antibiotics that are available without a prescription. Now, many of you may or may not be surprised to know that in most of the world, you can get antibiotics without a prescription. This is not new. In some parts of South America, for example, you can go into any street corner pharmacy and buy whatever they have on the shelf. Anything you want, you choose, have whatever you like. And of course, it produces tremendous problems. But in the US, it's become something increasingly of concern. The US has always been regulated with regard to prescription. Your doctor can't give you a prescription for give you antibiotics without a prescription, and so on. But you can buy them online. You can go into Mexico and buy them, although the law is changing there too. You can buy them in animal shops. It's all over the place, and it's of concern because people do this and think that they're doing something as, oh yeah, I've got a stomach infection, I better take an antibiotic. What shall I take? Oh, I think I'll take this or that. Not a happy story. And we really need to try and see how this can be controlled through education, because it's just really adding to the problem. So here we are from last July in the Lancet. Global consumption of antibiotics have a greater potential for driving resistance, nearly doubled from 2000 to 2015. I know this sounds like a really sad story I'm giving you today, and I'm sorry if I'm not giving you lots of happy news, but it really is of concern. So-called watch antibiotics, the ones that are really of concern that we need to be looking at, the broad spectrum that should not be used routinely, and particularly in low and middle income countries, are really the use is rising, and it's a very great concern. I could spend a lot of time. There's tons of literature. It comes out every week. Right, seagulls in Australia are carrying bacteria resistant to antibiotics. Here's one from Uruguay, colistin resistance. And colistin is a really, really important drug for use in medicine when other antibiotics are not functional. Denmark, highly civilized country, everything very, very tightly regulated. But in Denmark, it's the study from Aarhus showing that about 1 in 4 people in the world are carrying the TB bacillus in their bodies. Many, again, not to be alarmed, will be asymptomatic and probably carry it quite possibly through their lives. But dentists in the US, this is from the US, dentists are the highest frequency prescribers of clindamycin, highly associated with C. diff infection. Any of you who've had Clostridium difficile infection in your gut, or you know people, or your parents, or family, or patients, it's not a happy condition to have, and very difficult to treat. In fact, another story altogether, but the most successful treatment now is fecal transplants, using healthy fecal samples into the large intestine. Very successful treatment. Doesn't sound very much fun. It's actually important. And for years, the influence of the agricultural industry and farming has been very important in antibiotic resistance transmission. There have been campaigns trying to get farmers, people who produce animal products, to reduce the use of antibiotics. They're used, of course, to increase meat yield, for example, in cattle. And it was going down, and then, as you see here, data from last month shows that it's been increasing again. Not a happy story. And there's obviously an intention to try and get the FDA to step in, the Food and Drug Administration in the US, to try and do this. So, transfer of antibiotic resistance genes. This is from a recent study showing that they can come from all over, from habitats such as the water environments, animals, industry, and soil. And so it goes on. This is not a new phenomenon. As I said, you can buy antibiotics in some countries right over the counter there. And this is from a medical journal, but written by a Chinese physician who had gone back to China. And the problem in China, one of the problems in China is that physicians are often compensated by companies for prescribing and selling their drugs, not just antibiotics. And this has been translated, and any of you who can read will see it. So there's the cartoon is suggesting the patients are going in with their great sackfuls of drugs to the doctor, and the doctor is doing well because every time he prescribes something, he gets a kickback, a bonus, if you like, from the pharmaceutical company. I mean, the ethics of that, I hope, are not, don't need to be explained. The American Academy of Pediatrics has really tried, and the American Academy of Pediatric Dentistry has really tried to get pediatricians and pediatric dentists to reduce the use of antibiotics. And I know some here who have, actually. But when they did a follow-up study, they found that the compliance with their professional guidelines was very poor, 10 to 42%, less than half the pediatric dentists were going along. And it's this idea, oh, I better give an antibiotic just in case, which is not necessarily the right way to go. We know the neonatal exposure of antibiotics impairs child growth. And you'll say straight away, any of you have children? Yes, but if you've got a tiny child with an infection, you may need to use an antibiotic, and you may, but you may not. It may be that these are not always necessary. And very often it's the emotional part here. A parent going in with a tiny child says, you know, there's an infection here. We need to try and treat it. And understandably, you know, I'm a parent too. But judicious care, husbandry of antibiotic use is really important. And this, again, this is a study coming from China, but looking at WHO regulations just from last year, looking at respiratory infections. And again, the idea that many, many infections are viral, but people still prescribe antibiotics. I was very encouraged by endodontists, and not just because I know that there in TUMS, I have some wonderful colleagues who are endodontists. My great friend, Dr. Necrotizing, who I think is there somewhere, I see him there. And the American Association of Endodontists really looked at this. And it's interesting, my endodontic colleagues, if you go back to the literature from, say, 20 years ago, it was really all over the place. But then the endodontists got their act together, really, and produced some very fine policy statements, I thought, very sensible, and could be very good guidelines for many of the rest of us in terms of antibiotic use, where antibiotics are not indicated in a healthy patient and only under certain circumstances. And that position statement is available online, as you see, from 2017. I think it was a very sensible document was produced there. So as I was going through dentistry as a dental student and the first part of my career, the big thing was bacterial endocarditis. The patient comes in, oh, I had a heart valve problem, I had rheumatic fever as a child, oh, the knee-jerk response is we need to give antibiotics. Well, actually, that's not always true. And there were some people, Tom Palash, for example, for years used to talk about this. And I could spend a lot of time talking about this, but just to say, and I'm happy to hear anybody's comment on this, there never, ever was any objective evidence that dental treatment led to endocarditis, actually led to endocarditis in any patients. It was always this mythology. And certainly in a country like this, part of it was based on the concern that, oh, well, just in case there's a problem, I might get sued, and so I want to avoid it. It was lack of evidence and the fear of possible legal consequences leading to this inevitable knee-jerk response. When I took over, when I was still in England, I took over a periodontal department, one thing I started to do, every single patient who came in and said, I've been told I have to have antibiotics because I had rheumatic fever, or I have a cardiac valvular problem. Every single patient I sent to the cardiologist for an exam. And I'm not exaggerating when I tell you that 9 out of 10 times I got a letter back from the cardiologist saying, this patient actually doesn't need antibiotics for covering dental treatment. It was one of the best things in my life I got. They would save the patient repeated antibiotics, risk of infection, risk of resistance, and so on. But the sunshine came out for me in 2007 when the American Heart Association redefined risk and really took out a lot of patients from the category of requiring antibiotics to cover dental treatment. And really, that was an incredibly important moment. And of course, very quickly after, the American Dental Association followed suit. They took all the recommendations of the Heart Association seriously. And so by 2008, things were improving. Hopefully, people giving fewer antibiotics, and that turned out to be the case. And what was really encouraging was that in 2012, they published a 5-year follow-up to show that there'd been no increased incidence of endocarditis in the 5 years since the guidelines changed and fewer antibiotics being used. A nice piece of indirect evidence, I thought, and I really found that very heartening. The common sense and good clinical practice based on science was prevailing. So if any of you watch TED Talks, I would recommend Rob Knight's TED Talk. It's a 20-minute TED Talk on antibiotics. It's a few years back now, but you can find it. You just go to TED Talks and Google and search for Rob Knight. This is his little book, Follow Your Gut, which is quite humorous. His TED Talk, I think, is not only humorous, it's very enlightening. And I would look at this. But it's one of his conclusions is it's exasperating how much people worry about vaccines and how little they worry about antibiotics, which is a very appropriate thing to say now. This was before COVID, of course, and now we have a whole lot of people getting concerned about vaccines. But this was, I would recommend his TED Talk to you if you care to just spend 20 minutes looking at this. And our Assistant Secretary General for Health in the US last year, Dr. Giroir, he says, antimicrobial resistance, I do believe, is the existential threat of this century. So a little bit like Dr. Ibanez going way back there. You know, this is pretty heavy stuff coming from these serious people. Of course, there are people looking at other ways of treating bacterial infections. This is Ashley Karczewski is actually a third-year dental student with us, and she's done a lot of work looking at antimicrobial peptides already. She was an engineer and she came to dentistry later. She's done some remarkable work. And has spent she spent a year out in Africa doing some work there too, and looking at these. And I just use this as an example of ways in which people are looking. There is somebody called Hancock out in British Columbia, Vancouver, in Canada, who started up a small biotech company looking at antimicrobial peptides, amino acid combinations based on computer algorithms actually derived from horseshoe crabs that have a very highly antimicrobial peptides in their skin, of all things. I'm not an expert in that. I just thought this was kind of interesting, produced recently from England from last year. They found antimicrobial potions 1,000 years old in this text here that actually manages to treat antibiotic resistant infections. Something, you know, we shouldn't be surprised at. People have been looking at this for a long time. So through the World Health Organization, and you see this from Geneva, evaluation of awareness campaigns in antibiotic use, and it's very simple. Do not buy or use antibiotics without a prescription. Don't save leftover antibiotics, right? Common sense. Reduce the use of broad spectrum antibiotics, something I touched on a few minutes ago. Unused drugs should be returned to the pharmacy. And in most cases, you can find a place where you can return them. Don't flush them down the toilet. Don't throw them in the trash where it could get into the recycling and into the environment. Take them to the pharmacy and they'll dispose of them. And simple things, stay healthy, get enough rest, eat well. Don't use antibacterial cleaning products. You know, they took the Federal Drug Administration here, took away triclosan from all the hand washing products and shampoos and soap a few years ago, realizing it was a problem. And remember, one thing that is important, to be effective, a patient, anybody must have a functioning immune system. Your body needs to be as healthy, and that goes back to the previous point here, is you need to be healthy for antibiotics to work, generally healthy. It sounds maybe paradoxical because you're treating somebody who's sick, but generally people need to be immunologically healthy for antibiotics to work. And the best example of that, of course, is people have very severe immune deficiency, something I worked on some years ago, where antibiotics may not save your life if your body is not functioning. So what about COVID? I thought nobody's going to be able to talk in this conference without at least mentioning COVID. Well, you know, this is kind of interesting because lots of people have been talking about antibiotic use along with COVID treatments and hospitalized patients. Interesting that this study was published back in December last year. When I say last year, I mean 2020, last December, looking at superbug outbreaks, so-called bacterial outbreaks, where the bacteria are not amenable to treatment by antibiotics, regular antibiotic use, because people are using them too much. And this is kind of a busy slide here, but basically talking about the use of antibiotics. A lot of people using antibiotics in treatment just in case the patient, the COVID patient, gets a chest infection. And actually, the conclusion of this study from just a few months ago, that even though there are only 8% rate of co-infection, over 70% of patients were prescribed antibiotics. And the data now coming out about resistance in hospitals for patients who've been unnecessarily treated with antibiotics really is quite concerning, right? And then again, I mean, I'm just using this. You can, these are just papers to look up. And Journal of Antimicrobial Chemotherapy, very respectable journal, looking at the long-term impact of resistance here. And then here, this conclusion: whilst the urgent focus must be on controlling this pandemic, of course, sustained efforts to address the longer-term threat of resistance should not be overlooked. So this is something that is not going to go away anytime soon. Oxford University in England, as you know, is one of the partners in the production of one of the major leaders in the COVID vaccine, and in the sort of wake of all the work they've been doing. This photograph is the chancellor of the vice chancellor of the university, the chief of Oxford University, if you like, this lady here, this professor here. And the concern they have is that antibiotic resistance is one of the biggest problems in health, global health, worldwide. And so they are putting money, they've had money donated in order to establish an institute to work on antibiotic resistance. 50 researchers, that's a big, big thing. An AS Institute is going to be looking just at antibiotic resistance, and it's going to be important that the work they do, because they are predicting, as it says here, 10 million excess deaths, more than normal deaths, right, by 2050. That's long. And the vice chancellor's concern here is that, the COVID vaccine has created a very much bigger public awareness of university research and the value of experts. If any of you read Ed Yong, I would recommend it. He writes in the Atlantic Journal, a very prestigious journal, not a medical journal, but he's a very insightful scientific journalist. And as he says here, and I think this is the important part, the solution is not to demonize these drugs, but to deploy them judiciously in situations where they're actually needed and with full knowledge of the risks and benefits. I don't think I could put it any better. I said right at the beginning, my stand here is that these drugs are dangerous drugs. And I think what he's saying is yes, and not to make them, this is not cocaine or heroin. This is important, not opioids even. This is important, but they really need to be used very carefully. The data is out there. The science is in. There's no question that antibiotic resistance is a big problem. This, again, a very recent publication. Antibiotic resistance has been a slow-growing scourge, fueled in part by relatively weak political support for implementing national action plans, because the problem is essentially the result of multiple system failures. Overcoming it requires global collective action. And I think that is really important. It really is going to require a big joint effort in order to get this under control. So finally, I want to come right back, not just to Dr. Ibanez, but to the man who started all this, really, Dr. Fleming in England, in London, in 1945, right? So the discoverer of penicillin, he warned the public that doctors were abusing penicillin already by using it in patients who did not need it. He said, in such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with the penicillin-resistant organism. I hope this evil can be averted. Well, unfortunately, like Dr. Ibanez, Dr. Fleming's words were not totally heeded, and we now have these big problems. I just want to declare, once upon a time, once in my life was saved by antibiotics. So like Ed Yong, I don't want to suggest they should never be used, of course, but they should be used very carefully and very judiciously when used at all. I finished. I wanted to run. If I'd rushed through, I apologize, but I wanted to make my story to give you something to think about. I'm quite sure some of you will not agree with some of the things I've said. I have colleagues here, may I tell you, that don't agree with everything I say about this. But I do believe it's a concern, and I think somebody has to make a noise about it. So I'm just being noisy today about this. But I really thank you for your attention. I wanted to leave a little time in case there are any questions that you may have.
Okay, thank you very much, Michael, for your impressive, great presentation. I do appreciate your contribution in this panel. And also I would let our audience know that we can move from a lecture to a discussion panel, because we have two great authorities of the international affairs of the Tehran University of Medical Sciences, and also professors from endodontic department and also public health department. Professor Dr. Khami, thank you for joining us, and also Professor Nekufar, thank you for joining us in this panel. I think we have about 12 minutes to the end of this panel. Therefore, I would like, I think Professor Nekufar are working at his office. Therefore, please, first, Professor Nekufar, are you with us?
Yes, I'm here. Hello, okay. Michael, thank you very much. I was just in the clinic between my patients, so I had this opportunity to really enjoy from what you say today. And I wonder.
I think we will.
I just heard that Dr. Nekufar is wondering. I don't know what he's wondering.
Wondering and disconnecting. Okay. Also, we have Mohammed, Professor Khami. You are with us, and the platform is yours, and we will waiting for Professor Nekufar.
Thank you, Puyan. I would like to say hello and thank you to Michael, my dear friend. And I really enjoyed his presentation, and I think it was alarming presentation and lecture. So I just want to share the results of a recent study that we have done on self-medication on antibiotics before and after the epidemics of COVID-19. So the study has been done in northern part of Iran. So we have gathered information from the patient's records in one of the clinics, faculty clinic of School of Dentistry of Rasht, University of Medical Sciences in the north part of Iran. Actually, one of our recently graduated students working there, he could gather this data. So from two occasions, from mid-November to mid-February 2019, before the epidemics, and the second occasion were in 2020 from mid-April to mid-July. So if I can just share my screen, I can show you. This is unpublished data. We are now, we have submitted the paper, but I can show you some of the results here. Can you see the table?
Yes, I can. Yes, I can.
Yes, and you can see here that this is a logistic regression model showing that self-medication with antibiotics, this SMA, has been threefold after the pandemic. And this is alarming. So self-medication, it's self-medication with antibiotics. And according to these regression models, we can see that it has been more than threefolds. And the p-value is significant. We can see this is significant. And also we can see here, because the chief complaint of the patients referring to the clinics have also been recorded and reported here. Some of those results maybe can be explained here. You can see, for example, pain and pain, and then here this triangle is for pus and abscess. So the chief complaint after the pandemic has been raised. So the chief complaint, pain and pus has been an increasing trend from before to the after. But for example, the other reasons for referring to the clinic, for example, discoloration and aesthetics or hypersensitivity or something else, you can see decreasing. So because of pain, the patients then use and take antibiotics by themselves. And this is alarming. And I think in dentistry, because of the fear of our patients to be infected when they come to the dentist, they delay coming to dentist and they start taking antibiotics. I just wanted to share this as maybe in continuation of your nice lecture. And again, thank you.
No, Mohammed, thank you. That's very interesting. I presume you're planning to publish that. That's really, it's of course interesting and alarming. So I just want to check with you. So is that because the drugs are freely available in that part of Iran? People can just buy them. You don't need a prescription for the antibiotics.
Yes, they need prescription. They do need prescription. So if the patients want to take some of this, they should have been prescribed. But usually patients, they use, for example, when they have some antibiotics in their home, when they have toothache, they started using and taking those antibiotics. And I have the name of the medications here.
Right.
Commonly used medications, but all of these should be prescribed. It is not; they are not over-the-counter drugs.
Yes, that's fine. Well, that's important. And if I may just, and I don't want to stop anybody who has a question or a comment, but I didn't say it. And I see there are quite a few comments in the chat, and I imagine we won't get to all of those. But first of all, I want to thank everybody who's put something in the chat, your nice comments, and also there are some questions there. But one thing I didn't say is that, of course, what we are not good at in medical or dental practice is doing sensitivity testing in infections. Nobody seems to want to wait, to get it, and it's pretty quick these days. You don't have to wait a week to get the result back from the lab, and prescriptions are usually given without any sensitivity testing at all. And I'm telling you, we are not perfect by any means here. I have this conversation with my colleagues here in the clinics. People will come with an abscess, an infection, and say, "Oh well, usually penicillin works, or usually clindamycin works, so that's what we'll use." But you're shooting in the dark almost at the infection, and it's not a surprise sometimes that it's not the outcome isn't satisfactory, or it could take longer. And of course, in the meantime, you may be inducing resistance. By the way, I'm not suggesting my slides are wonderful or incredible, but I'm very happy. Maybe you already have the slide presentation downloaded there, Poyan, but if you don't, you can have it. I mean, I'm happy for anybody to have access to this. And if you sell it, make a lot of money, make sure you send some of it to me. That's all. But it's available, and of course, for anybody who wants to communicate with me about this, my email address is there in the site. But sorry, anyway, any other comments or questions?
Okay, thank you, Michael. And Professor Nekufar, are you with us? Do you have my voice? I think he's
treating a patient. Yes.
In COVID-19 time, the economy situation is very difficult, so I have to work and teach at the same time.
Right. Yeah.
So I've been disconnected, but my question was about the prophylactic antibiotics for endocarditis. And I, as an old school endodontist, I would say, sometimes when I have abscess, I prefer to have antibiotics before actually initiating the treatment for the patient, especially if they are at risk of somehow, as we said, endocarditis. You mentioned that there is a recent study about 5 years evaluating the patients by changing the protocols. But still, I'm suspicious sometimes about some patients. What do you think about that?
Well, Mohammed, I would say, what I said before. If you have the opportunity, if you don't have to do the treatment as an emergency, every patient I used to be responsible for, and maybe that sounds crazy. Actually, it wasn't so many. It was maybe 1 or 2 every week at the most. And the cardiologists I worked with were very happy to see the patients. And I send them for an assessment. And then for me, if I have the letter signed by the cardiologist saying this patient does not require antibiotic prophylaxis for dental treatment, then that goes in the file. And if I had to go to court, which I never did, but if I would have to go to court, I would have that letter there. I can tell you very quickly, I used to go to lecture at Baylor, as it was in Dallas, in Texas. And they, at the periodontal department, had a case where a patient had treatment for perio, and a few weeks later had a brain abscess. And the patient, they never proved it, but the patient sued the university and the dental school for being responsible for the brain abscess. It was never proven, but the university, in order to avoid a long process, they settled out of court for $3 million, right? A lot of money. What I really respected was that the school didn't change its policy on antibiotic use on the basis of that one case. And I really think that's really important. As I said, you can prove me wrong. I even went to my legal colleagues to look up the legal history here in the US. There is no successful prosecution based on fact, only on supposition, nothing based on fact in dentistry that endocarditis, and certainly a fatal endocarditis, has been caused. Nowadays, if you look at the literature, by the way, on endocarditis, the biggest risk population is the opioid users and intravenous drug users for endocarditis. Dentistry has fallen down the list of concerns.
And my last question is about the prions, because as you know, in endodontics, prions also are very important, and we consider a lot of problems in terms of removing them from endodontic files. What do you think about that?
Yeah, I actually don't have any expertise on that, Mohammed. You're asking me something that I don't really know. I've read something on that, but I haven't really. I don't really have any expertise on prions, and I'd be untruthful if I said otherwise.
Because in the UK, for example, they said that we shouldn't use endodontic file twice because it's almost impossible to remove prions from the burrs or from the endodontic files, to remove them, and even a sterilization cannot help for that purpose. So I think that can be one of the questions for the future, to work on that a bit more, because it has huge effect on the business of dentistry as well.
Right. That's interesting. Yeah, I'm always willing to learn. I was not aware of that.
Okay. Thank you very much indeed, and thank you very much from all my colleagues and the steering committee of this winter school. I'm very proud of these young people that now they succeed all of the Office of International Relations. Thank you very much all, and goodbye, and see you tomorrow.
Thank you for being with us, and because of time shortage,
my pleasure.
I have several questions. I have several questions from our audience, but if Professor Kowolik, if you would let me, I will share your email with our audience, and they can send their questions to you, and I will be grateful if you would reply them.
Absolutely.
At the end of this session, I would like to thank you again for sharing your great experiences with us, Professor Kowolik, and I would like to ask all audience to turn on their cam to have a group photo at the end of the 3rd day of the first virtual winter school of Tehran University of Medical Sciences. Thank you very much.
What about microphones? Should we open it as well?
Oh, the webcam is enough. Thank you very much.
It's lovely to see you. I hope to be there in person one of these days when they'll give me a visa again. That I'm waiting to be there.
We miss you and hope to meet you again.
I need to have more of Bush.
Yeah, exactly.
Yes.
Thank you very much.
Thank you.
Thank you, audience, Professor Kowolik, Professor Khami, Professor Nekufar, and have a nice day and meet you tomorrow morning with the 4th day of the virtual winter school of Tehran University of Medical Sciences. Have a nice day. Bye-bye.
Thank you.
Welcome.